ladies and gentlemen. At the outside, I would like to thank organizing committee for giving me the opportunity to present this case. I'm Dr. Tejas Shah. I'm assistant professor at Department of Cardiology, Dheeraj General Hospital. So coming to the case history, she doesn't have any significant coronary risk factors. She came to medicine OPD with a complaint of atypical chest pain on and off since one day. And from there, she was referred here for TMT. The baseline ECG was normal. We advised her TMT. We gave her admission to the medical ward. She went to OPD, went to ward, and sister suddenly called me. Patient has severe diaphoresis. I advised to take ECG, and ECG shows gross ST elevation, inferior lead. Lead 3 more than 2, and there was a reciprocal changes in 1 in AVL. So I was expecting a lesion in the proximal RC, and I immediately took her for the CAG and PCI. Before that, her vitals were 72, pulse was 72 per minute, blood pressure was 110/70. Echo suggestive of inferior hypokinesia, and there was a RWM to RC, para-LV systolic function, and grade 2 central jet MR was there. Systemic examination was normal, so she was in Calip class 1. And primary treatment which I gave was, I loaded her with aspirin, 60 mg of prasugrel and 40 mg of rosuvastatin. Started IV fluids, and I gave bolus unfractionated heparin 16 10 per kg IV bolus. This was her angiogram. It shows there is a lesion in the distal circumflex 70 to 80%. Proximal to mid LAD there was 40 to 50% stenosis. And in LAO caudal view, you can clearly see there is a lesion in the circumflex. It was a discrete lesion, 80% stenosis. This RAO cranial view shows 40 to 50% lesion in mid LAD. This was the RC issue. It shows, I was expecting it was 100% thrombotic occlusion, but it was open and it shows 99% discrete stenosis type A lesion. So I thought first I will handle the RC. I took 6 French JR with 3.5 curve, and usually I use in PAMI filter FC wire, hydrophilic wire. I crossed the lesion, and I pre-dilated the lesion with 2.8 RTMS compliant balloon with 6 to 8 atmospheric pressure. There was slight yielding. I thought I will go ahead with the direct stenting. I took 3/21 supralimous gray stent, and after confirming the position, I deployed the stent at 11 atmospheric pressure, 12 atmospheric pressure, and this was the after deployment. There was slight under expansion before the RV branch, so I thought to pre-dilate it with the 3.58 NC Apollo balloon, and I have pre-dilated, and this was the last shoot. She had TME3 flow, she was stable, and probably now the real story begins. I thought I will handle the circumflex also at the same setting, and 3.5 curve 6 French JL I have taken, I have engaged, and I have crossed the lesion with filter FC wire. At this stage I thought probably I will do the direct stenting, and I took 2.75/21 mm supralimous gray stent, and after confirming the position, I have deployed the stent at 11 atmospheric pressure, and the expansion of the strut and body looks okay. So this was the after the deployment of the stent, and the moment I came to RAO caudal view, and there was a perforation, at least grade 3B, and I was not knowing what went wrong, but there was a perforation. Everybody was panicked. Now what to do? And she developed immediate pericardial effusion. First thing I did was I inflated a stent balloon below nominal pressure. I kept inflated, started IV fluid. Pressure went to 80 systolic, but she was stable. There was no tachycardia. She was maintaining the blood pressure. So I just kept inflated balloon for at least 2 to 5 minutes. After inflation, actually my primary aim was if I am able to reduce the leak, and she had impending tamponade, so at least before tapping the blood or before tapping this fluid, let me try to minimize the leak. So I kept on inflating and deflating the balloon. There was a slight reduction, but after 5 minutes when I check it again, it has not given me a great result. So meanwhile, see there was still the leak was persisting, and in fact Other option were like whether to reverse the effect of the protamine, because I have given the tirofiban infusion also, but I was worried for the RCA, so I didn't give it. Somehow I was able to manage the graph master, that is the cover stand of 2.7518, and this I am positioning the stand. This is graph master cover stand. Once I have positioned, then I have deployed the stand, and after deployment, once I have confirmed there was no significant link, then I have tapped the frank blood, almost 200 ml of blood, and with aseptic precaution I have done the autologous transfusion, same. And she was on minimal dose of ionotropes, IV fluid, and 100 to 125 ml of autologous transfusion I have done. She was stabilized, and you can see pericardial cavity that staining has removed, and leak was there, but not much as compared to the previous. So once she was stabilized, she was shifted to the CICU, and she was monitored. Now coming to coronary artery perforation, as we all know, there are 3 types, and it has been classification has been given by the Ellis, and the incidence in large study it has been reported 0.8 to 0.43 to 2.9%, which is more in the CTO case. Now, what are the variables? Variables in the study which has been found that use of GP2B3 inhibitors, Lapman disease intervention.
For a shorter time, stop theory. We'll come to practical point.
Yeah.
Come to conclusion.
Yeah. So now coming to my main talk, what are the evidence whether when the patient with acute anterior or inferior or acute MI comes, whether we should do the culprit after culprit vessel, non-culprit vessel has to be handled or not. So there are studies which says that in European Heart Journal which published that approximately 50% of the patient of acute MI have other vessel involvement.
Okay,
and
point of discussion is not the culprit vessel, let's come to perforation.
What are the recent recommendations for culprit versus non-culprit intervention? Like ESC guideline says it is class of recommendation is 2A, level of evidence A.
Okay, you can read these books, please. Next.
Yeah.
And yeah, come.
Now take home message is culprit versus non-culprit intervention. It's always a matter of debate. If patient is stable, recent recommendation you should always perform. As far as perforation is concerned, factors responsible like complex coronary anatomy.
Come to your case. What was the reason in your case?
No, in my case.
Theory, we all know what are reasons.
Yeah, sir. My case probably 2 things which I observed that I have not prepared the bed properly, and second thing.
No, that's not the reason. Next.
Second, oversizing of the stand.
Definitely oversizing of this reason. Yeah. In this patient, you see the first shot after inflation, probably exposed.
How much was the stent used? 3.5?
No, sir, 2.75. In circumflex, 2.75.
So we have to find out what was the cause of perforation. You managed it well. So you think it's oversizing, Dr. Raman? You say?
Yes, sir. That's right.
Can we see because we have to see that again.
It was definitely oversized.
Rather than understanding.
In my experience, when you have new inflation device, you suddenly go up. I have done. When old one will go slowly. So it means probably must have gone suddenly up. That actually caused oversizing of the stent was not size 2.7 but is not large. Probably has gone into higher pressure unintentionally. That probably has made the stent
know how much pressure you.
The stent size in this picture is like 3 millimeter now.
11 atmospheric pressure.
10 atmospheres.
11 atmospheres.
I am just telling you this could have been one reason. Otherwise, oversize is the main reason.
Yes, sir.
But just want to see the picture
relative point of first doing on the site balloon inflation or pericarditis depends upon the clinical situation of that particular patient. There is no theory what we should do first. We should do according to requirement on the bedside. If there is going to be compromise, let somebody start pericardial tamponade and you start inflating balloon. You can do it simultaneously.
Yes, sir.